People often ask me does anticoagulation fit into the palliative care setting, and I think the first thing we have to do is define what do you mean by a palliative care patient. And this is a real challenge, because if you're talking about a patient who has incurable disease, well, someone with metastatic breast cancer, that disease is incurable, but for some patients it takes on a chronic disease trajectory. So that person will be living with cancer for a long time. People who have advanced cancer, whose performance status has deteriorated, who are nearing the end of life, I think we should treat them as a special case. Decisions should be made on an individual basis. I think what we know is as someone approaches death, the risk of bleeding does increase. We've also had some data recently which would suggest that deep vein thrombosis and large deep vein thrombosis is highly prevalent in patients entering the hospice without any additional symptom burden or survival disadvantage. So I think in the hospice population, in people with very poor performance status who have been deteriorating over time, I think the role of thromboprophylaxis, so prevention, I think should be called into question. But I think we have to look at what we're trying to achieve when we give thrombosis treatments and anticoagulants. If we're looking to control a symptom, I think it is reasonable. If we're trying to use it to prolong survival, I think the risks of bleeding actually outweigh the benefits of symptom control, especially when we're entering end-of-life care, where the symptoms attributable to pulmonary embolus, for example, can be managed with end-of-life drugs.